All right. Alrighty. So welcome everyone. Thank you so much for joining us for the 2023 PI conference. My name is Rebecca Russ, and I will be the moderator for today's session, Overview of SCID from Diagnosis to Treatment. And I'm so excited to welcome Dr. Kapoor, who will be presenting on this topic to you today. There will be time for questions at the end of the presentation, so please go ahead and submit any questions you may have for our presenter today in the Q&A section of your platform. Also, today's session is sponsored by Chiesi, and we're very grateful for their ongoing support of our education and our learning opportunities. So Dr. Kapoor received her MBBS degree at Himachal Pradesh Medical College in the year 1972. Dr. Kapoor did her postgraduate training in pediatrics at Brown University in Rhode Island and did her subspecialty training in hematology, oncology, immunology, and bone marrow transplantation at Memorial Sloan Kettering Cancer Center and Cornell University in New York. After finishing specialty training, she held a faculty position at Memorial Sloan Kettering Cancer Center. She is a professor of pediatrics at Keck School of Medicine at the University of Southern California. And over the years, she has set up 4 new transplant programs in different parts of the country. Since 1996, she is the director of the Blood and Marrow Transplantation Program and Blood and Marrow Transplantation Laboratory at the Children's Hospital Los Angeles and professor of pediatrics at the University of Southern California. Dr. Kapoor's research focuses on stem cell transplantation in patients with primary immune deficiency and other genetic disorders. Another major research interest of hers is the use of alternative or half-matched donor transplant when a suitable histocompatible donor is not available. Her other research efforts are to build immunity in the immediate post-transplant period and recovery of the immune system post-transplant. She has more than 150 papers in peer-reviewed scientific journals and has active laboratory research in stem cell transplantation with clinical application. Dr. Kapoor has been a member of the board of directors for the American Society of Blood and Marrow Transplant and Cell Therapy. She is a co-chair on the Committee for Primary Immune Deficiencies, Inborn Errors of Metabolism, and Other Non-Malignant Marrow Disorders, and co-chair of the Graft Engineering Committee in the Center for International Blood and Marrow Transplant Research. So thank you so much for joining us, Dr. Kapoor, today. And with that, I will turn it over to you.
Thank you very much, Ms. Bass, for a very kind introduction and asking me to participate in the symposium. This is my privilege to be here and to share some of the information which I have with the people who are vested in it and want to hear more about it. As you can see from my title, it's the overview of severe combined immunodeficiency. And I want to emphasize really the word overview. There's not really that we can go through any details in this short period of time. So it's more of an introduction, and so that we can share where we are and which direction we are moving ahead in this particular field. All right, I do need to see if I can. All right, so primary immunodeficiency diseases, which we are called PID, or nowadays the new name is Inborn Error of Immunity, IEI. That's the new name. We keep changing names so that we can be fresh all the time. These are the group of diseases which are either due to deficiency or dysregulation of immune system, affecting various components of immune system, such as neutrophil, macrophages, dendritic cells, natural killer cell, T cell, B cell, or even complement component. And effect on these cells can lead to susceptibility to infection, uncontrolled inflammation, or autoimmunity. So in reality, but this field is moving very fast, and anytime I present the slide, my slides seem to be outdated. But even current time, there are more than 485 distinct primary immunodeficiency disorders which have been identified, and more than 400 gene mutations have been identified as a causative factor for these diseases. And each time, as I said, I feel outdated because for sure, if next week there will be more genetic disorders which have been identified or more diseases which can be attributed to those are recognized. Now, the spectrum of these diseases can vary. They can be very mild, just like somebody having repeated colds or some allergy type of reaction, or it could be sublethal, that yes, there's a disease, but not killing people, but it can be also lethal disease. And the immediate intervention or recognition is very necessary for those cases. And the lethality is due to infection, inflammation, or autoimmunity, or cancer. So any of these can lead to end of life for some of these patients who are affected with these diseases. The most severe form of the primary immunodeficiency diseases is called severe combined immunodeficiency, SCID, which is the diagnosis recognized as very important and serious. I'm just still trying to organize this. It's recognized as medical emergency. That is something which we all realize, and for some time, that this is a very serious complication, and we do need to recognize it and do the intervention as quickly as possible to protect these patients. So in our facility, we, as I mentioned, and as Ms. Bhatt has mentioned, that yes, I'm involved with the transplanting patients with primary immunodeficiency. And in this pie chart, you see this very colorful pie chart, that there are variety of different immunodeficiency diseases for which we have done the transplant, but the half of the pie of this pie chart is the children with the severe combined immunodeficiency. And it's not that this is the most common disease, but it is that anyone who recognizes this patient does refer the patient to us immediately for the management. So this is the most common which come for medical attention and for the treatment, but there are a variety of other primary immunodeficiency for which we do undertake the transplantation. Okay. Now, talking about that blue part of the pie chart, that's the severe combined immunodeficiency. It's the boy in the bubble. If you are remembering that particular case, that's the disease where they have deficiency of both T cell and B cell. And it's a heterogeneous presentation. This disease, which we call SCID, is not one type of disease. There are variety of abnormality which can lead to that combined immunodeficiency. Combined means the deficiency or non-functioning T cell and B cell. And these are, of course, rare disease, just like you're talking about the rare diseases in this whole symposium. But sometimes it is fatal diseases which we are dealing with, and then there are congenital abnormality which is seen in these patients. Inheritance of this disease, what we recognize at present time for many of these cases is X-linked, where the mothers carry the genetic mutation and it's expressed on the male children of that family with a 50% chance of being affected. It could also be autosomal recessive, that means both parents carry the gene, and this the transmission of the disease happen in the child if they have inherited the similar gene from father and from the mother. Okay, and occasionally it could be spontaneous mutation in the fetus. Neither of the parents carry the gene, but the child may have the disease just because of spontaneous mutation. In most of the cases with the severe combined immunodeficiency, they don't produce T cell. And if they're producing T cell, these are non-functioning T cell. Secondly, they also do not necessarily produce immunoglobulin. And if they do produce immunoglobulin, they do not make specific antibodies in those cases. So most of the children with severe combined immunodeficiency at birth, they appear normal. You know, they just like any other child who was born. Only occasional case who will have dysmorphic feature, who may have congenital heart disease, they may have some skin or skeletal abnormality. So, but other than that, majority of the children born with severe combined immunodeficiency, they look any other child, normal appearance for most of the cases. All right. So most of the patients who are diagnosed to have severe combined immunodeficiency, these patients acquire multiple persistent and severe viral, bacterial, or fungal infection shortly after birth. Now, yes, I said shortly after birth for the reason that for first few months after birth, there is enough protection from mom to the baby because there's through placenta, the antibodies have gone in. That's the IgG class antibody from the mother to the baby, and that protects the baby for a while. But as you know, that when you hear about intravenous gamma globulin, that the half-life of that is about 28 days. So by third month post-birth, that's gone through 3 half-lives. The levels really go down. And at that time, the children can present with the infection, viral infection, because they are sitting in this common open environment, which they can get exposed to these viruses and can have the infection. So that's a very common presentation. And what happens, and just to give you an example of a story, that yes, the child has a fever, went to pediatrician, even though there was some evidence of otitis media because there's maybe viral infection that caused it. But pediatrician gave the amoxicillin saying, oh, this is infection, otitis media. And what happens? That wipes out the normal bacterial flora and child then shows up with a thrush in the mouth. Very common thing. And thrush become more disseminated. And then children, those affected children are failure to thrive because they develop candida enteritis or variation within that. And then if these children are not recognized, they rarely reach their first birthday without any definitive treatment. So very important thing to recognize that they are looking normal, healthy, born children. They look normal like any other child born. But then within few months after their life, if they are not identified and taken care of, yes, they can have serious complications and die because of those complications. All right. So at present time, that how do we then diagnose and what is the frequency, how often that does happen? Yes, we are dealing with the rare genetic diseases, but there are about 35 different genetic defects which have been identified, which can be associated with so-called severe combined immunodeficiency. And when we are looking at present time, that how often that happens. So there may be 1 in 40,000 to 1 in 100,000 live births that the child which is born may be affected with the disease, the severe combined immunodeficiency. So there are about 40 to 100 new cases of severe combined immunodeficiency born in the US each year. Okay, as I mentioned to you, generally the median age for the diagnosis of this disease used to be 4 to 7 months of life. We did not make the diagnosis before that time, but now things have changed. That was, remember, that was what I had explained, that for first few months you have maternal protection. So that used to be median time when we used to see these patients. But nowadays in the US, we have newborn screening program where all newborns are screened for severe combined immunodeficiency. That's primarily looking at the T cell. Okay. Now the question really comes up that how many kids really having that testing done? Actually, almost 99% of the kids born today are getting tested. So if you remember that every baby is having that the heel stick with the on the Guthrie card for all those other diseases, PKU and all that other stuff, the SCID has been also added into that analysis. And now every child born is evaluated for T cell deficiency when they are born at that time. Okay, in California, we started screening. Actually, the screening process started in 2008, and in California, we started doing that 2010. So, and now every state is doing it. Right now, if you're talking about SCID, there are 2 types of SCIDs. There are SCID, classical SCID, and then leaky SCID. Classical SCID are who are born without lymphocytes, so that you're saying that yes, their lymphocyte count, unexplained lymphocyte count, less than 500 per microliter. That's a very low count. And normally that for majority of the children, we will see that there is by a few months of life, they definitely should have lymphocyte count greater than 2,500. If it is lower than that, we need to think about there's something that's wrong in those cases. So classical SCID have low number of lymphocytes. And then, of course, if we do the further analysis, then we start thinking about the T cell, the B cell. Those lymphocytes will also be abnormal and lower in number. Okay, but there are infants who may have T cells and who may have B cells, but they do fall into the category of severe combined immunodeficiency because their cells, either they are lower in number or they don't function properly, just like I told you early on that the numbers could be low and their function could be abnormal. So in those cases, these could be the leaky SCID because numbers are there. They could be this is low number, they could be even normal number, but in some cases, the lymphocyte number could be even high. So as I said, they are known as leaky SCID, and I call them as tricky SCID because, you know, if I was just practicing somewhere in my private practice and as a pediatrician, I would look at the lymphocyte count and they look pretty normal. So I'd say, how would I know that this is a child with a severe combined immunodeficiency? So it's very important that I can only see if I know what I should be looking for. So here I see what you know. That's a very important thing to recognize. So our education of our other medical provider becomes very important there. But this problem has actually become less significant since we are doing newborn screening. So that is an assurance for the people who may have to deal with this sort of situation or our medical provider, that recognizing that no, these children are being screened. So it's very important that to pay attention, that don't just go by number. We need to say, if the screen became normal, as if numbers are fine, no, that requires further investigation because there are recognized diseases of severe combined immunodeficiency that where the number could be even, you know, normal number like ZAP70 deficiency, where the one population of T cells, that's the CD4 positive cells, they're there, but CD8 positive cells are absent in those cases. And these children act just like any other severe combined immunodeficiency. Or patients who have Omenn syndrome, and I'll talk about that a little bit more, that these children have the cells, okay? And not only have the cells, they probably have more than what we would see otherwise. But if we do not know that this is another track word, that the special test which we do is a track analysis for newborn screening. If that is abnormal, this particular child needs further analysis and needs to be looked at more definitively, saying what these cells are and what they look like. So that's a very important thing. So we need to see that there are normal cells. They are not oligoclonal, and I'll go into a little bit more details a little bit later. And they're young cells, naive cells, because those are the ones which are being developed in our body through our thymus. So they should be coming out in our circulation. If those are not there, the naive cells are not there, then there may be cells which were old cells somewhere stopped in the development, and they will be the old cells, that RO positive cells, which I have listed here. So that type of analysis become absolutely necessary. There is another situation where the cells are there in the circulation, the T cell, but those cells are actually not from the baby, but these are from mother. So as you know, during pregnancy, there are always little bleed from baby into mom and from mom into the baby. Now, normally, yes, if that happens, our body, our immune system reject those cells. They are foreign cells. They shouldn't be staying in our body if we have normal immune system. But in these babies with a severe combined immunodeficiency, they don't have normal immune system. So they cannot reject any cells, which are foreign cells. So these cells persist in the body, the T cell, because T cells are very unique. They just don't die off like a neutrophil or some of the other cells. We have shorter life. T cell can persist themselves and propagate themselves for a long period of time. So these cells would be maternal derived cells. So if I found that on screening, I do have abnormal screening, I would do the testing. And then I would look at those T cells to make sure these are not maternal cells. So we do have to do those testing before we can give exact name, what kind of SCID it is, and what's the origin of those cells? What are they doing? So that's a very important part. So as I said, these tricky SCID, the leaky SCIDs, that yes, in some situation we find that they are more present there. One of the syndrome, which is again not that common but is present, is the Omenn syndrome. So in these cases, children have high number of T cells. They may be missing B cell, but they also have NK cell. Now, when we look at these lymphocytes, they are actually developed from the baby, and they're just going crazy. They're multiplying more and more. But in this situation, these cells are so normally we have diverse group of T cells. That's our body is recognizing the different antigen and then develop T cells in response to that. But in these babies, they do have a T cell, but that's a very small clone. They are not the diverse clone which we see normally. So in those cases, they can be just going crazy. They are not necessarily functional, but they can continue to grow more and more. And this defect goes with the genetic mutation, with the RAG mutation, that how the gene rearrangement happens. So this is a serious situation because these children then present with the high IgE and high eosinophil, which is another white cell present in our body. But these are classical presentation that can happen. They have the red skin, their liver spleen gets, as time goes by, liver spleen gets big. They have enlarged lymph nodes, and sometimes they end up losing their hair. Those are things which happen. So this is a very important thing because I have had one child referred to us, but that child has seen, they thought that this rash, the red rash this child had, was related to some allergies. Had seen about 5 allergists before that child got referred to us, before we were able to establish the diagnosis and undertake the transplantation. And he did well with the transplantation, but as I said, recognizing the problem is very important. And fortunately for us, with the newborn screening, that part has become very easy, that we should not be ignoring it just because the cells are there. We need to investigate and make sure that those cells are identified and saying, are they functional or they're non-functional? Are they from mother or they are from the child? And if they're from the child, are they diverse population like normally should be, or they are the oligoclone, that means small population, and they are just proliferating. All right. So one important thing to recognize that even though we say the severe combined immunodeficiency is either missing T cell, B cell, NK cell, or they are, if the cells are there, they are not functional cells. Because there are, so ultimately it is that there's not a function of T cell and B cell, normal T cell, normal B cell. That's what leads to severe combined immunodeficiency. But the causes for that is very, very, it's a heterogeneous reason that why that can happen. I have put this slide up there primarily for us to say that there are a lot of genetic variation which can happen. And you will say, okay, what are you going to do? You're still going to transplant this patient to correct it, right? That's the primary thing, that's the established thing. But there are other treatment also which is necessary. And more important thing is that even if I was doing transplant, depending upon what is the defect there, I may prepare the child differently, because some of those can tolerate the chemotherapy, others cannot. Some of those need more aggressive chemotherapy, others need less. So there's this important reason why that genetic analysis becomes very necessary, even though I may say it's a severe combined immunodeficiency. All right. So just within our own program, as you can see this nice pie chart, that there's a variety of severe combined immunodeficiency for which we have undertaken the transplantation. Of course, the RAG 1 and 2, which I had mentioned, which goes with the Omenn syndrome, that's the bright blue colored portion of the pie chart. And the most common one is the the primary X-linked SCID. That's in the largest number of portions. And then there's an ADA deficiency, which is a green portion of the pie chart. That's these are common presentations, but they are all different variety of presentation, for which we should know, because then we can prepare the patient properly and we can undertake the definitive procedure on them. Okay, so workup for that question is that, okay, this newborn screening came back as abnormal, then what do we have to do? So initially repeating the CBC and making sure that are the lymphocytes are there or not. That's the one most important part. After that, the second test which we send for is the TB and NK phenotype. That means by looking at whether there are, how many T cells are there, how many B cells are there, how many NK cells are there, and what are their subpopulation. That gets looked at it. And the next step would be to look at the function of those cells which are there. Do they respond? Like we should be saying, immune cells should be responding when we do the laboratory test. Okay. Then we have to look at the serum immunoglobulin. And the question really becomes, it's not IgG class which we look at it. Primarily, in this case, would be IgM, because at birth, the baby has almost as much IgG as the mom will have, because that goes from placenta to the baby. So IgG is not the one which we are looking at primarily, but it is an IgM. Of course, if I was testing 3 months down the line, that would be a different story. But if I'm testing it within that first month, when my newborn screening comes back, then it's an IgM which has been looked at. And then, of course, a lot of time people forget to look for IgE, because that's not the significant immunoglobulin. So, but that's a very important information if I was dealing with Omenn syndrome. And I mentioned to you that newborn screening is done with the track testing. It's in a special excision circle. When new T cell is formed, these circles are made when the new T cell is being formed in our thymus. So if they are less than 25 per microliter, and each lab have different values. So I would not go on that particular value, but that's the value in our laboratory. So that we have a lowest possible level, which we say that it needs to be above that level. But for our laboratory, anything 25 and less is abnormal. So we have to have higher than that number. Okay. And then one most important part, as I said, that we do need to do genotype. That's the genetic analysis. Very critical. Yes, it does take minimum of 2 weeks and maybe sometimes 6 weeks to do that analysis, but it's very important for us for multiple reasons. One is that how we're going to condition these children for treatment, what type of treatment would be necessary, what they can tolerate, and what's the best possible treatment for those children if we want to define the genotype. In this workup, one of the standards which was established few years ago when unfortunately we had high incidence of HIV, so because there also the immune system gets affected. So we had to make sure that we rule out that there's not HIV in those cases. It's not the common thing which happens, but this is still our standard in our workup for the diagnosis of the immune deficiency. All right. So also in the process, we have to rule out that there's not oligoclonals. The T cells are there. We have to do the clonality testing there. And we have to look for the young versus old cell. So these are the marker for the CD445RA is the marker for young cell, but our O positive cells are the marker for the old cell. So we have to establish that, because if it's RA positive cells are there, that means thymus is working fine. It's making new T cells. We don't need to worry about it. But if they are all RO positive cells and no RA positive cells are seen, then we need to worry about it. And then, as I mentioned to you earlier, the maternal engraftment is a very important part. It's a very small population. So it's not every laboratory can do this testing. So it has to be that whatever blood we are taking from the baby, we have to sort out those cells with our fax machine. And then we do the what we call STR, the short tandem repeat by genetic marker. That is the thing, are these cells from the baby or are these cells from the mother? So those testing are done by specialized laboratory. So, but it's very important that as far as completion of workup, this must be done. All right. Now, severe combined immunodeficiency. I very briefly told you that how you diagnose it, and now the question will be the treatment. And we have made tremendous progress in this field of treatment of these patients, and matter of fact, in transplantation. So our very first successful stem cell transplantation was done from a histocompatible sibling donor in Minnesota in 1968. That was the biggest landmark and that has very important thing. And I'll tell you that I am very proud of this accomplishment which has happened in our field, that yes, that before that, allogeneic transplant was never done successfully in any situation or any disease. So this was the first successful transplantation. In 1973, first successful unrelated donor, histocompatible, that means somebody who's a tissue match donor, transplant was done. It was done in New York at Memorial Sloan Kettering. In 1980, the first successful haploidentical, that means half-match transplant, and which is a very important thing to recognize, that why it becomes so important, that not everybody is going to have a donor, and we'll talk about that a little bit later again. That the first successful haploidentical transplant was done again in New York in a child with severe combined immunodeficiency who did not have a matched sibling donor or unrelated donor. In 1987, when the To Be the Match or National Marrow Donor Program was established, that became the standard of care for the transplant for the immune deficiency patient, and that brought forth that yes, it's done with severe combined immunodeficiency as a first attempt. In 1995, the first gene therapy was also done in ADA SCID, and that was an NIH. So these are the major milestones which has happened in our field of transplantation and cell therapy. And each one of those were first successfully done in severe combined immunodeficiency. So I'm very grateful for those situations, and we'll talk about that they have given us the opportunity to learn about how to proceed in this field of cell therapy. Now, this is a picture of our very first successful allogeneic transplantation, which was undertaken in 1968. 5 years ago, we celebrated the 50th anniversary of this successful transplantation. He is alive, doing well, and that's our longest follow-up in the field of transplantation, who received the transplant from one individual to another individual. And since 1968, the transplant from histocompatible donor became the gold standard for BMT. That was very important thing, and not only for severe combined immunodeficiency, but many other diseases. All right. So therapy for SCID, which has been well established, so hematopoietic stem cell transplantation is the potentially curative treatment for all types of SCIDs. That's enough, and is well established. And our experience, as I said, now it's 50 years plus experience we have had in this field. So it's a very important part of us to recognize this is an established treatment. The second treatment, which is an enzyme replacement therapy, and it's at present time is only available for ADA SCIDs, adenosine deaminase deficient SCIDs. So for those, we can give enzyme replacement therapy if they are not the candidate for transplantation, or we don't have the donor. So for longest period of time, we use Allogen as the product, which was these children were treated with. But now we have recombinant new product, which is called Revcovi. So that is the enzyme we have available, and with a very good results. It was done, one of our patients who we had been following since age 8, and she's in her 30s now, but she was one of the candidates for who was also, when the study was being undertaken, that she was one of the subject in that study. Now, the most exciting thing which is happening is the gene therapy, and which is being done for ADA SCID for many, many years, as I said, since 1995, and X SCID. So that's another very important thing to recognize, that these things can be cured with the gene therapy. That's the new horizon for us to really explore and for us to really expand our treatment modality. And besides that, obviously, that protective isolation, immunoglobulin replacement therapy, and prophylactic treatment for fungus, PJP, viruses, all these precautionary measures needs to be observed not only before the treatment, but even after these, even transplantation, till we have evidence that there's an immunological reconstitution that needs to be continued. Okay. Now, essential steps for the allogeneic transplantation is, first and foremost, is that identifying the patient with the disease treatable with a stem cell transplantation. And as I mentioned to you, that I really at present time prefer that we have as a standard in our institution, that we establish the genetic mutation on this particular cases, because their tolerance, some of the kids are not able to tolerate the conditioning regimen, which we can give for many other children as a standard part of the treatment. So once we know that what subtype it is, then we can tailor it according to that particular child's need. Other part is that now we also have option to offer them the gene therapy. Will you want to offer gene therapy if I know exactly that what's the gene defect is? Is that the X SCID who could be referred to for gene therapy? Or is the ADA SCID who could be referred for gene therapy? Those are the ones which once we know that genetic mutation, then we can decide accordingly that way what part needs to be done. But if we are just sticking with the stem cell transplantations, as I said, once we have genetic mutation identified, then we can say, okay, this is a child treatable with a stem cell transplantation. So that's the first step. Second part is for identifying the suitable donor for stem cell source, who can be our donor for the transplantation. And we'll talk a little bit more later. The third part is the conditioning regimen. Again, and conditioning means preparing the patient for transplantation. And these are the things which we talk about. In some situations, we don't do conditioning. Other, we just do immunosuppression. Other, we condition by immunosuppression and myeloablation. And then we talk about reduced intensity and non-myeloablated. And this could be subject in itself for talking about, but we'll talk a little bit more in detail at later time. And then it's the infusion of stem cell. It's given intravenously. There's no magic in there. Just like blood transfusion, it can be given intravenously after patient has been conditioned for transplantation. Post-transplant immunosuppression becomes necessary in a standard type of transplantation. It's not like when you do the kidney transplant or major organ transplant where the immunosuppression is required for a long period of time. It is to be required only for 6 to 12 months, only for the reason that the mature T cell from the graft can react against the baby, the recipient who is getting the transplant. So we need to keep those immune cells under control, and ultimately those mature cells will die out. The new cells, new immune cells will come from the stem cell, which will go to the thymus of the infant, and then from there, new immune cells will grow, and they become tolerant to the recipient. So they do not fight against it. So once there's a tolerance, we do not need to give any more immunosuppression. So they should be having normal balanced T cell, B cell without those cells trying to fight against the body of the recipient. Okay. And then ultimately is that we want to be sure that their immune reconstitution has occurred as we expect with the transplantation. Okay. So we're going to talk about identification of donor and also conditioning regimen a little bit more in detail. Okay. So availability of donor. We recognize that there are, in genetic diseases, there's about 25% chance that we're going to have histocompatible donor in the family, 1 in 4 chance. Okay, but somebody also healthy and able to really react against it. So that's an important thing to recognize. Less than 5% will have other related donor. Chances of finding outside the SIP ship is much less. Okay, for 70-75% of the patient, we need alternative donor, and there we are looking for unrelated donor for marrow as well as peripheral blood stem cell. Okay, so right now there are 12.5 million volunteer donors in the registry, and there are about 850,000 cord blood products which we can access for finding a donor if we don't have sibling donor. Worldwide, there are 25 million people who are available for us to look at it. And the probability of finding a donor is about, even with all that number, is somewhere 29 to 79%, depending on what the race we are dealing with. For Caucasian, there's a higher chance of finding a donor. But let's say if I was dealing with an African American, no, there's not going to be that good a chance for me to find a donor in the registry. Okay, and that means 10 to 40% of children who are candidates for the transplantation but do not have match related or unrelated donor. And in those cases, we can give half match transplantation. So that has been my, love for a long period of time. And we have been doing these type of transplants since 1980. Now, conditioning regimens, so you say, well, these are immune deficient patients. Why do we need to condition these patients? But we need to be that early on, historically it was that when we first started doing transplant for immune deficiency, we didn't do any conditioning of these patients. We took the stem cell from the donor and dumped it into the recipient. And majority of them who didn't have, who was classical SCID, they got engrafted with T cells, but they did not necessarily have engraftment of B cell. In 80s, we started saying that we do need to, and not 100% cell patient got engrafted even with the T cell. Okay, so in 80s we said no, we do need to have some immunosuppression to prepare the patient for transplantation. So we started giving ATG and cytoxin to those. In 90s, what we realized that yes, we are getting T cell engraftment, but not B cell. So in that case, we said we do need to make a space so that stem cell can be engrafted from which the B cells grow. Because B cells are so the one which are infused will not persist. So they will die off. So for them to grow from anywhere, we needed stem cells there. So that was the big thing that we started doing myeloablation. That means we are creating the space there for the new stem cell. And from stem cells, there will be T cell and B cell will be growing. In 2000, that became the standard of care. Yes, some places that treosulfan is available, but if that's not available, busulfan is the one which is used for immunosuppression. What the recent study has shown that it was not only because we were concerned about B cell engraftment that we are giving myeloablation. There are studies coming out that if we were doing the transplantation without myeloablation, even T cells will kind of decline over 20 to 30 years. So for getting that persistent engraftment, we are saying that no, myeloablation is necessary in those cases to get the whole thing to be established in post-transplant period. But the questions are being asked. Nobody likes to give chemotherapy. These are toxic agents. So nobody likes to give this chemotherapy to these young babies. That, toxic agents, they do have their adverse events related to those. So we have now studies going on, trying to find what is the minimum amount which we must give to get the graft established without really ending up with a lot of toxic effect. So those studies are in progress right now. And actually there's a new study where we are not giving any chemotherapy or radiation therapy. This is a monoclonal antibody, which is called antibody AMG191. That takes away that stuff where the old cells are sitting and opens up the niches for the new cell. So you can establish the graft without having given chemotherapy or radiation therapy. So this is a very important development in our field. Again, this is still an investigative phase. So we have to be careful that where we want to take this chance or not, but that's an important thing for recognizing. Okay. So over the years, we definitely have made a big difference how the results are coming out of the transplantation. So this is a lower line in this graph. You see that's the transplant done between 1974 and 1999. We were getting about 70% event-free survival. But if you look at the top line, because since we started doing newborn screening, and so these are from 2010 to 2016, that's analysis, sorry, okay, that we now have 94% event-free survival there. If patient comes to us with the infection and all that, of course, there we are probably 75% event-free survival. But if they come in good condition, we have very good results in that. So there was further analysis of that was done and showed that children who were transplanted before 3.5 months of age, we are talking about 98% event-free survival. patient who comes into us after 3.5 months of age and have active infection, there we are talking about 50% survival in those cases. So very important for recognizing. And this was one of the this study was very compelling force for us to say that we need to do the transplantation on this. We need to recognize these children as soon as possible. And that's what became very effective, that yes, we do need to do newborn screening. And every state in the United States is now doing this newborn screening. Okay. Now, infection question is, did we really make that difference by newborn screening and how these children get infected? Because infection was the big issue. We did find the patient who had family history, there the risk of acquiring the infection within that first month, while we are still investigating these children and confirming the diagnosis, they probably got as high as they had. They did acquire some of the viral infections, especially viral infections, but the babies who were born where there was a family history, I guess family was right from very birth, before even we had a confirmation of diagnosis, were more careful. And there the risk of infection was much less in those cases. So it was 19% in the, 19% in the families where there was a family history, compared to 55% risk of acquiring the infection that first month of life. So that was a major difference. So it does make a difference of taking the precautions early on, very important to keep them free of infection. But what was known, that patients who were just done with the newborn screening and still went to transplantation within the before 3.5 months of age, and the patient with the family history, the outcome was very similar in those cases. There was not that much of difference. All right. Now, very quickly, I want to go over the gene therapy. That gene therapy has been, as I said, the very first successful gene therapy was done in SCID in 1955. The procedure of that is rather simple, that we take the cell from the infant. Okay, these cells are genetically modified. The abnormal gene is corrected. In the meantime, they are given a little bit of chemotherapy to create the space, and then genetically modified cells are given back to them. Okay, and that was very exciting, and it came along. But unfortunately, in 2009, we had a halt this whole process for the reason that 5 out of 20 SCID, 7 out of 10 of viscous tolerance, 3 out of 3 chronic granulomatous disease, but 0 out of 42 ADA SCID had leukemia. And that made us go back and look at it. What are we doing different? What we need to do different to make it safer and not have leukemia? Because other kids did. So we didn't want to throw the baby with the bath water. It's a very important concept and probably doable in the cases. So now, instead of using the lentiviral retroviral vector, which was being used before, now self-inactivating lentiviral vector is being used to introduce that corrected gene in the stem cell of these babies. Okay, and that had been actually very good. Actually, they showed that every ADA SCID obviously were doing fine, but that was, sorry, I think I'm missing one slide, but there was now with the lentiviral vector, there are cases now almost for last 7 to 10 years that they are doing fine and not developing leukemia as it was noted before. So that has made it, because the viral vector is in the self-inactivating, so it is not promoting the growth, uncontrolled growth of the lymphocytes. Okay, so now this showed that 20 infants which were transplanted for the SCID, X SCID, they had reconstitution of the T cell as well as of the B cell, and they had gone off the requirement of IVIG. So that's a very important thing would be, why would you be so excited you can get that done with their regular transplantation? No, there are some complications related to regular transplantations like graft versus host disease, graft failure. Those complications, it can be eliminated because these babies are getting their own cells back, would be much more important. So family with their full information that who we are offering it and how we are doing it, if with their full consent and with their full understanding that yes, we can undertake this particular transplant procedure, the gene therapy procedure. Now, gene editing is a very exciting approach which is coming along, and that's I'm sure you guys have heard about the different technology which is for gene editing is coming along, and most common which is being used is the CRISPR technology with Cas9. The advantage of that is that we know exactly where this introduction of new gene needs to be. So if there was abnormal gene, we just cut it off and have those two parts of the DNA joined together. And I'll show you the example. I guess not. So in this situation, that if there's an abnormal gene or normal gene needs to be edited into that particular area, it's the exact place. We know where we are introducing that particular gene. And remember that in our genetic material, there are something which we call promoter or regulator genes. So they are the ones that say how much any particular cell should be proliferating, how much expression of this gene should be happening. So there are regulatory genes which are in exact location. They are not just going random anywhere. So this is a very safe way of saying the natural regulatory elements are there. So hopefully that will be much better, safe harbor for these new genes to be there, which will then correct the defect. So in summary, that what we know that yes, severe combined immunodeficiency, first thing is the heterogeneous group of drugs, disease, and some of them are lethal, no question about it. So we do need to have prompt diagnosis, definitive therapeutic intervention as needed to provide the cure of the disease. But we also recognize that tremendous progress has been made in the diagnostic process, treatment, including the supportive care. That has also gotten better since we first started doing the transplant in these patients. And I call the severe combined immunodeficiency patient as our teachers. What we learned from them in their treatment is now applicable in the treatment of many diseases, not just in the immune deficiency, but many diseases. So I have my greatest thanks and gratitude to our patient and their family who trust us for doing the right thing for their children. So thank you very much.
Wonderful. Thank you so much, Dr. Kapoor, for providing that overview. I don't know about you guys, but that was just fascinating to me, you know, all that detail about SCID and all the different diagnoses. I think that we probably don't have time for Q&A at this time, but just want to kind of remind everyone that everyone's treatment and condition are unique, and the information presented during this session was not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always make sure to seek that advice of your physician or other qualified health professional with questions concerning a medical condition. Since we did have a few questions come through, just want to remind everyone that if you would like an answer to your questions, to go over to Ask IDF, and that is a great resource that you can reach out to IDF staff. We can talk about some of the questions that you might have. We can even reach out to Dr. Kapoor to, you know, facilitate a conversation there. So just want to say thank you so much for everyone joining. Thank you so much, Dr. Kapoor, for joining us. It's been great to join you, today in this session. As a reminder, we have 39 unique learning opportunities throughout the conference. So we hope to see you tuning in to some other topics today. And thank you again to our partner, Chiesi, for supporting this learning opportunity, and just hope everyone has a great day. Thank you so much, everyone.
Thank you. And thank you for this opportunity.